We'll be breaking down all major concepts covered on the exam. Uh, think about the human skull for a second. It is a rigid, unforgiving bone box.
Oh, absolutely.
Yeah, you have brain tissue, you have cerebrospinal fluid, and, blood. The moment you add a fourth element to that closed system, like a tumor, you suddenly have a massive real estate crisis.
Right, because location dictates absolutely everything.
Exactly. The central question you always need to ask yourself when looking at neuro-oncology is this: is the tumor sitting on the front lawn pushing against the house? Or are the roots tangled up deep inside the plumbing? I'm Harvey, and I'll be guiding you through today's material.
And I'm Donna. We're MCCQE reviewers, and our mission here is to help Canadian medical students feel a whole lot more comfortable with the exam review process.
Definitely.
But before we really get into the weeds, a brief disclaimer. This deep dive is for medical education purposes only. It's not medical advice, and any clinical decisions must always involve a qualified healthcare provider.
So today's S08 neurology focus is brain tumors. We're looking at some incredibly rich material from recent StatPearls articles covering meningioma, acoustic neuroma, and astrocytoma.
Which is a lot to cover.
It is. And if you just try to memorize all the genetic markers in clinical presentations, it's going to feel like an impossible list.
Yeah.
But if you frame it all around that real estate concept, the physical space these masses occupy, the pathology actually starts to make perfect sense.
It really does. And it makes sense to start with the most common primary central nervous system tumor, which is the meningioma. It makes up over a third of them.
Wow, over a third.
Yeah. And this is our classic extraaxial tumor. Like, it's the one sitting on the lawn, pushing on the house. Extraaxial is the operative word there.
Right, because they arise from arachnoid cap cells, meaning they originate from the meninges surrounding the brain, not the brain tissue itself.
Exactly. Because they grow from the outside in, they typically don't invade the brain parenchyma, they just compress it. And if you look at the epidemiology in the literature, there is a very distinct female predominance.
I always found that detail so fascinating. Like, why would a brain tumor care about the patient's biological sex?
Right.
But it turns out this isn't just a random piece of trivia. Meningiomas actually express hormone receptors on their cell membranes, specifically progesterone, estrogen, and androgen receptors. The data shows progesterone receptors are present in over 70% of these tumors.
Which sets up a very classic clinical vignette for the MCCQE. You might see a case where a patient's tumor grows rapidly during pregnancy.
That's a huge clue.
It is. Or a patient reports neurological symptoms that mysteriously fluctuate with the luteal phase of their menstrual cycle. The circulating hormones are literally binding to the tumor and stimulating its growth.
That is such a great testable concept. Now, beyond the hormonal aspect, there are a couple of other major risk factors. Obviously, a history of prior ionizing radiation to the head is a big one. But then there's the genetic trap. Most of these are sporadic, but if there's a genetic mutation, you have to think about neurofibromatosis type 2, or NF2, which involves a mutation on chromosome 22. We'll definitely come back to NF2 in a bit.
Yeah, we'll see that one again.
For now, I want to talk about how a meningioma actually presents on the ward. Because it's pushing from the outside, the symptoms are completely dependent on which part of the brain it's squeezing.
Right. The location is everything. So if the mass is sitting over the brain convexity, pressing on the motor cortex, the patient might present with contralateral paresis. But the exam loves to test specific, complex anatomical spaces.
Right. Which brings me to a presentation I used to always mess up. A patient walks in with anosmia, total loss of smell.
Okay.
You look in their eyes, and they have optic atrophy in one eye, but papilledema in the other. How does a single tumor cause atrophy on one side, but swelling on the other?
Ah, that is Foster-Kennedy syndrome, caused by an olfactory groove meningioma. If you think about the physical mechanics, it's actually a beautiful piece of clinical logic.
Okay, walk me through it.
So the tumor is sitting right at the base in the frontal lobe. It grows and directly crushes the olfactory nerve on that same side, which explains the anosmia.
Makes sense.
It also physically compresses the ipsilateral optic nerve, strangling its blood supply and causing optic atrophy.
So the nerve on the same side is just totally crushed and dies off.
Exactly. But remember, this tumor is a large, space-occupying mass. Even though it's only crushing local structures on one side, it's taking up volume inside that rigid skull we talked about.
Right, the bone box.
Right. This raises the overall intracranial pressure globally. That generalized pressure is transmitted across the entire brain to the opposite optic nerve.
Oh, I see.
And since that opposite nerve hasn't been physically crushed by the tumor yet, it swells up from the pressure, giving you contralateral papilledema. Local compression causes the atrophy. Global pressure causes the swelling.
It's just simple physics applied to neuroanatomy.
Yeah.
I love that. When we suspect this, we order an MRI with gadolinium contrast. The classic buzzword everyone memorizes is the dural tail sign,
Oh, yeah, you always see that one.
where the contrast enhancement sort of tapers off along the dura, stretching away from the main tumor mass like a comet tail. But there's also the white matter buckling sign. It sounds like a car crash, but what is physically happening to the brain there?
The white matter buckling sign is the ultimate radiologic proof that you are dealing with an extraaxial mass.
How so?
Normally, the junction between the gray matter on the surface of the brain and the white matter underneath has a specific wavy contour. When a meningioma grows from the outside, it acts like a fist pushing into a balloon.
Oh, that's a great visual.
The brain tissue doesn't tear, but that gray-white junction gets physically deformed and buckled inward.
It just proves the tumor is pushing the brain rather than infiltrating it.
Mm-hmm.
And if we biopsy that mass, we're looking for somoma bodies. These are concentric mineralized whorls.
Little tree trunks.
Basically, yeah. As the meningothelial cells in the center of the tumor die off, calcium deposits around them in rings. Now, if the tumor is small and asymptomatic, we often just watch it. But if it's causing mass effect, we go in surgically.
And surgical success is graded by the Simpson grading system. This predicts a risk of the tumor coming back based on how much tissue the neurosurgeon removes. Grade 1 is a complete radical resection of the tumor, the attached dura mater, and the affected bone.
Wait, so they can't just scoop the tumor out? They have to take the surrounding tissue too?
They have to. If you leave the dura behind or only do a partial resection of the mass, the Simpson grade goes up and the recurrence rate absolutely skyrockets.
Wow.
You can't just pluck the weed. You have to dig out the topsoil it was growing in.
Okay, so meningiomas are often hanging out on the surface of the brain, pushing inward. But what happens when an extraaxial tumor decides to set up shop in one of the most crowded, high-rent districts of the skull base?
You mean the cerebellopontine angle?
Yes, the CPA. This is the realm of the acoustic neuroma, which makes up about 80 to 90% of all CPA lesions. I do have major bone to pick with the literature here, though.
Oh.
If we know for a fact that this tumor originates from the Schwann cells of the vestibular portion of the 8th cranial nerve, why on earth are we still calling it an acoustic neuroma? It's not acoustic, and it's not a neuroma.
You are preaching to the choir. It is a massive historical misnomer that refuses to die.
It's so frustrating.
Pathologically, you are entirely correct. The accurate term is vestibular schwannoma. But medical traditions are incredibly stubborn. You have to be prepared to see both terms used interchangeably on the MCCQE.
Good to know. Let's look at the real estate of the CPA. It's a tiny triangle formed by the cerebellum, the pons, and the skull base, and it is just packed with cranial nerves.
Extremely cramped.
Because the tumor originates on the vestibulocochlear nerve, the classic presenting triad is unilateral sensorineural hearing loss, tinnitus, and vertigo. But as it grows, it starts elbowing its neighbors.
And the expansion is very predictable. As the mass bulks up in the CPA, the first neighbor it usually hits is cranial nerve V, the trigeminal nerve.
Okay.
This physical compression knocks out the sensory feedback from the face, leading to an absent corneal reflex or facial numbness. If it keeps growing, it compresses cranial nerve 7th, causing facial nerve palsy.
So it's literally just working its way down the line.
Exactly. In extreme neglected cases, a massive vestibular schwannoma will actually push into the brainstem itself, which disrupts the cerebellar pathways and causes severe ataxia and gait abnormalities.
Let's talk about the NF2 exam trap, because we touched on chromosome 22 earlier.
Yeah.
If a patient comes in with a vestibular schwannoma, how do you know if it's just bad luck or if it's neurofibromatosis type 2?
It almost entirely comes down to age and symmetry. If you see a patient in their 50s or 60s presenting with a unilateral tumor, a single mass on one side, that is a sporadic mutation.
Okay, so older and one-sided is sporadic.
Right. But if a clinical vignette describes a patient in their 20s or 30s who is complaining of bilateral hearing loss, and imaging shows masses in both CPAs, that is the absolute hallmark of NF2.
That's a huge difference.
Bilateral vestibular schwannomas equal NF2 until proven otherwise.
Under the microscope, schwannomas have a very distinct duality. The histology shows two specific patterns, Antoni A and Antoni B.
The classic A and B.
Yeah, and the way I like to visualize this is thinking about music. Antoni A tissue is like a tightly synchronized professional orchestra. The spindle cells are compact, highly organized, and they interweave in this beautiful, dense framework.
That's a great analogy.
Thanks. But Antoni B tissue is like a chaotic, late-night jam session. The cells are loose, randomly dispersed, and full of fluid-filled cystic spaces. What is physically happening to the tumor to create those two totally different environments?
It all comes down to blood supply and ischemia. The tumor starts out as that highly organized orchestra, the Antoni A tissue.
Right.
But as the tumor grows larger and larger, the tissue in the center outstrips its blood supply. It becomes hypoxic. That organized Antoni A tissue suffers from poor perfusion, breaks down, undergoes necrosis, and degenerates into that messy, cystic Antoni B tissue.
That makes so much sense. It's essentially tumor decay.
Precisely.
For diagnosing it, MRI with contrast is the gold standard. The classic radiologic description you'll see on the exam is the ice cream cone sign, or the trumpeted internal acoustic meatus.
You gotta love the food analogies in medicine.
Always. The tumor starts inside the internal auditory canal, that's the cone, and as it bursts out into the CPA, it expands into a round mass, which is the scoop of ice cream.
Such a clear visual.
When it comes to management, neurosurgeons use approaches like the retrosigmoid or translabyrinthine routes. But if you have an OSCE patient where you are counseling a patient before this surgery, what complications do you absolutely have to warn them about?
You have to explicitly warn them about facial nerve paralysis and hearing loss. Because the facial nerve is draped directly over the tumor capsule in that tight CPA space, dissecting the mass away frequently traumatizes the nerve.
Even in the best hands.
Even in the best hands. Postoperative facial nerve paralysis occurs in 15 to 30% of patients. Furthermore, trying to save the patient's hearing is incredibly difficult. Irreversible hearing loss happens in more than half of all surgical cases.
Wow, that is a tough conversation to have with the patient. So far, we've entirely focused on the squeezers, the extra-axial tumors like meningiomas and schwannomas that push from the outside.
Right, the front lawn tumors.
Exactly. Now, we need to shift our focus to the intra-axial infiltrators. These are the roots tangled deep in the plumbing, arising from the brain parenchyma itself. Let's dig into astrocytomas.
Astrocytomas arise from astrocytes, which are the star-shaped glial cells responsible for supporting and nourishing neurons. They are the most prevalent form of glioma.
And what causes them?
Unlike the tumors we just discussed, the etiology here is mostly unknown, with one very clear exception. Ionizing radiation is the only well-established risk factor. You should always be on the lookout for a vignette featuring an adult who received prophylactic cranial radiation for childhood acute lymphocytic leukemia many years prior.
Oh, that's a classic MCCQE setup. When an astrocytoma starts growing inside the brain tissue, the clinical presentation is usually a mix of general increased intracranial pressure, early morning headaches, nausea, vomiting, and focal symptoms based on the specific lobe it's infiltrating.
Right.
But there is a massive exam pearl hidden in the presentation data. Fully 50% of patients with supratentorial brain tumors present with seizures. Why is the cortex so prone to misfiring just because a tumor is nearby?
It's a combination of physical irritation and chemical imbalance. The infiltrating tumor disrupts the normal cellular architecture, but it also alters the local neurochemical environment.
In what way?
These tumors often secrete excessive amounts of glutamate, which is an excitatory neurotransmitter, while simultaneously downregulating the receptors that clear glutamate away. You end up with a highly irritable, hyperexcitable cortex that spontaneously discharges, resulting in a seizure.
So they're basically bathing the brain in excitatory signals. To diagnose an astrocytoma, we use an MRI with gadolinium, where they typically appear T2 hyperintense and T1 isointense. But there has been a monumental shift in how we classify these tumors, specifically the WHO 2021 classification update.
Oh, this is critical for the exam.
Histology, just looking at the cells under a microscope, is no longer enough to make a final diagnosis. Molecular diagnostics are now completely mandatory, and the absolute star of the molecular show is the IDH mutation status.
Isocitrate dehydrogenase. You must know this enzyme for the exam.
I always tripped up on this because it feels backward. Usually when we hear mutation in oncology, we think things are getting worse. But having an IDH mutant astrocytoma is actually associated with a much better prognosis and significantly longer survival compared to an IDH wild-type tumor. Why does a mutated Krebs cycle enzyme make a brain tumor less aggressive?
It does sound counterintuitive, but think of IDH wild-type, the unmutated version, as the default pathway for primary glioblastoma, which is a brutally aggressive, fast-growing tumor. The wild-type cells are metabolically efficient at growing and invading.
Okay.
When the IDH gene is mutated, the enzyme produces an abnormal metabolite called 2-hydroxyglutarate. While this metabolite does drive the initial formation of the tumor by altering the cell's epigenetics, it ironically creates a slower-growing, less aggressive tumor compared to the terrifying baseline of a wild-type glioblastoma.
So the mutation basically derails the tumor from becoming its most lethal possible version. That is a crucial distinction.
It really is.
Let's transition to medical management traps, because this is where the MCCQE loves to test your ability to integrate basic pharmacology with clinical care. Imagine we have a patient with an intraaxial astrocytoma. They have significant surrounding grain edema, they are experiencing seizures, and they are bedbound. Let's tackle the edema first.
Okay.
We always reach for corticosteroids, but specifically dexamethasone. I know we need to reduce inflammation, but if we give a standard steroid, don't we risk bloating the patient with massive water retention?
Exactly, which is why dexamethasone is the drug of choice. It has virtually zero mineralocorticoid activity.
Oh, I see.
You get all the potent anti-inflammatory action needed to stabilize the blood-brain barrier and reduce the vasogenic edema, but you completely avoid the systemic sodium and water retention that other steroids cause, which would be disastrous for someone whose intracranial pressure is already critically high.
But there's a trap here for the OSCE stations.
Yeah.
If you prescribe high-dose dexamethasone, you are shutting down the prostaglandins that protect the stomach lining. If you forget to co-prescribe gastrointestinal ulcer prophylaxis like a PPI or an H2 blocker, you will fail that aspect of the station. Now, what about the seizures? The standard guidelines point us toward levetiracetam. I always want to reach for the classic anti-epileptics like phenytoin or carbamazepine, but we actively avoid those in neuro-oncology. Is that a liver issue?
It is a profound liver issue, and it's a beautiful test of your basic sciences. Phenytoin and carbamazepine are potent inducers of the hepatic cytochrome P450 enzyme system.
The CYP450.
Right. Think of CYP450 as the liver's garbage disposal. If you give phenytoin to a brain tumor patient, it ramps that garbage disposal into overdrive. The liver will rapidly metabolize and clear out the patient's chemotherapy agents and their dexamethasone before those drugs can even work.
Oh, wow. So you're just flushing the chemo out.
Exactly. You will render their life-saving treatments subtherapeutic. Levetiracetam, on the other hand, does not significantly interfere with that hepatic microsomal enzyme system.
It's all about not sabotaging your own treatment plan. The next major management trap is venous thromboembolism. Brain tumor patients are incredibly hypercoagulable. Their risk of developing a clot is around 20 to 30%.
Very high risk.
But if I'm a junior doctor on the ward, I'm going to be terrified to prescribe blood thinners to a patient who has a vascular mass sitting in their brain.
It's a completely natural fear. You're worried the anticoagulation will cause the brain tumor to spontaneously hemorrhage, but the clinical literature is very clear on this protocol.
What's the protocol?
Prophylactic and therapeutic anticoagulation is safe, and it is strongly indicated for these patients. The immediate risk of dying from a massive pulmonary embolism far outweighs the relatively low risk of a spontaneous intratumoral hemorrhage.
Trust the literature over your gut instinct.
Got it.
The last major concept for astrocytomas I want to hit is a radiologic illusion called pseudoprogression. Let's say your patient finishes a grueling course of radiation therapy. A few months later, they get a follow-up MRI, and the scan shows a progressively growing, contrast-enhancing lesion right where the tumor used to be. The ward doctor panics, assuming the cancer is back and growing aggressively. But how do we know it's not actually the tumor?
You have to look at the physics of what radiation does to tissue. Radiation therapy damages the local endothelial cells lining the blood vessels. This causes massive localized inflammation, and the blood vessels become leaky.
Okay, leaky vessels.
When you give the patient MRI contrast, it leaks out of those damaged vessels and pools in the necrotic tissue. On the scan, this radiation necrosis looks absolutely identical to a rapidly growing active tumor.
That is terrifying.
It's a false alarm, and it requires advanced imaging techniques, or sometimes even a biopsy, to definitively differentiate from true tumor recurrence.
The scan is essentially taking a picture of the battlefield damage, not necessarily the enemy returning.
That's a great way to put it.
Let's zoom out and recap the journey we've taken today. We started on the front lawn with our extraaxial tumors. We explored meningiomas, recognizing their hormonal drivers, the physics of Foster-Kennedy syndrome, and the mechanics of dural tails and psammoma bodies.
Right.
Then we moved the CPA to look at vestibular schwannomas, tracking their compression of cranial nerves, the critical NF2 bilateral trap, and the ischemic origins of Antoni B tissue. Finally, we dove deep into the plumbing with our intraaxial infiltrators, the astrocytomas.
The
We
infiltrator.
broke down the metabolic shift of IDH mutations and navigated the pharmacological minefield of treating edema and seizures without inducing CYP450 and ruining the chemotherapy.
If you can master these specific presentations, understand the underlying physiology driving the symptoms, and recognize those pharmacological traps, you will secure major points on the MCCQE. The exam board wants to see that you understand the why behind the disease and how to safely manage the patient holistically.
Without a doubt. Before we wrap up, I want to leave you with a final, mind-bending thought that isn't quite in the standard review textbooks yet, but it builds perfectly on everything we just discussed.
Ooh, I like these.
We talked about how astrocytomas physically infiltrate the brain tissue, irritating the cortex and causing seizures. But cutting-edge research is now showing that some brain tumors actually form functional electrical synapses directly with healthy neurons.
Wait, really?
Yeah, they are literally wiring themselves into the brain's neural circuitry, hijacking the brain's own electrical signals to fuel their expansion.
That completely blurs the line between the host tissue and the tumor pathology.
It does, and it raises an incredible question. If these tumors are acting like functioning, communicative brain tissue, could the future of neuro-oncology involve treating brain cancer with psychiatric drugs or targeted anti-epileptics specifically designed to block neurotransmitters?
Oh, wow, that is wild.
It puts a whole new spin on the idea of roots getting tangled in the plumbing. Something to ponder as you review your neuro notes tonight. Thank you for joining us on this deep dive. Keep up the hard work, trust your preparation, and we'll see you next time.